To begin our panel, Faith in Practice, we welcome Dr. F. Michael Gloth, MD, who is the Corporate Medical Director for Mid-Atlantic Healthcare, the Medical Director for 3 local nursing homes, and an Associate Professor of Medicine, and the former Director of Outpatient Services in the Division of Geriatric Medicine and Gerontology at Johns Hopkins University School of Medicine. Dr. Gloth served at the request of the Secretary of Health and Human Services on the National Advisory Council on Aging. He's a past president of the Hospice and Palliative Care Network of Maryland, the Baltimore City Medical Society. He's also author of Fit at 50 and Beyond, it's a nice title, A Smarter Guide to Diet and Exercise as We Age, and the editor of the textbook Pain Relief in Older Adults. Dr. Gloth has been the recipient of the Best Practices Award from the National Organization of Hospice and Palliative Care, and was the 2006 recipient of the American Geriatric Society Clinician of the Year Award. Let us welcome Dr. Gloth.
Thank you very much. I'm a little bit height challenged, so I'm going to stand to the side here. Do Not Go Gentle Into That Good Night is a poem by Dylan Thomas. And I want to recite that for you and have you think about it as I do so. Before I do that, I am going to try to get through a few objectives relatively quickly in this talk. We will talk about the current state of living and dying in America. We will try to contrast that with how people want to end their lives and how they want to live until they die, and what actually happens in the medical profession in our society. We'll talk about the role of caregivers. We'll try to provide some insight into this physician-assisted suicide mess, and then talk a little bit about the physician's role overall in terms of end-of-life care. Do not go gentle into that good night. Old age should burn and rave at close of day, rage, rage against the dying of the light. Brave men, the last wave by, cry how their frail deeds might have danced on a green bay, rage, rage against the dying of the light. Wild men who caught and sang the sun in flight, they learned too late, grieved it on its way. Do not go gentle into that good night. Grave men near death, who see with blinding sight, blind eyes might blaze like meteors and be gay. Do not go gentle into that good night. And you, my Father, upon the sad height, curse, bless me now with your fierce tears, I pray. Do not go gentle into that good night. Rage, rage against the dying of the light. That poem casts an imagery for all of us. It certainly makes us think about preservation of life, but it also helps us to recognize that Dylan Thomas perhaps did not fully appreciate our own mortality, and the fact that no matter how much we want to continue to live, there comes a time when we will succumb to death. And all of us in this room recognize that that is the beginning of another life. Interestingly, mortality and our inability to continue to live, let's face it, in all of history, no one has gotten out of this life alive. We recognize that as a medical profession, we have spent a great deal of energy, resources in trying to provide cures and fighting against death, where death is the enemy. In the past, and take, for example, in the early 1900s, the average life expectancy was only 50 years. Well, childhood mortality was very high, and that counted for a lot of that. Adults might have lived into their 60s, and it was unusual to have anybody living beyond that. In the past also, we didn't really have the issue of antibiotics. People died relatively quickly, predominantly of things like infectious diseases or accidents. Medicine focused on caring, and there was a tremendous focus on comfort as well when people were at the end stages of life. The sick were often cared for at home, although there were some cultural variations to that. Medicine has clearly had a shift. Death, as I mentioned, is viewed as the enemy. There are a variety of organizational promises that are out there in terms of what we can and can't do. The technology is such that we can put tubes into more than every orifice in your body, and we have a false sense that we can sometimes provide care or cure when it is probably well beyond our grasp. Unfortunately, many of my colleagues have a sense of failure if the patient doesn't survive, despite the fact that we know that all of our patients ultimately will die. And despite our best efforts, and the best clinicians I know still have their patients die at some point at the end of their lives. How that happens, I represent up here in the first of a series of slides that I will discuss what happens in terms of life and function, and ideally what we try to accomplish in terms of medical school teaching is to have people continue with a very healthy status, very functionally active until right at the end, and then they will die. A sudden event. Interestingly, less than 10% of folks have a life that goes like that, and those incidents that do occur, it's either a traumatic event, and this really illustrates we know neither the day or the hour, and suddenly something will happen. If you think about it, Christ's life was like this. He had a sudden event at the end. He didn't have a long, prolonged illness. He died very suddenly. But the reality of it is few people will have an existence like that. In some respects, while we may not know the hour and the day, we get some clues. There will be a decline in terms of health. And this illustrates this slow, relatively short terminal phase down in here, but a continual gradual decline. And some people would argue that certain malignancies are like that, or even that something like Alzheimer's disease may take a path similar to that. More often, we actually get a lot of clues in terms of the day and the hour. You will have individuals that will function relatively well, and they will be checkered by periods of poor health. They may get into a hospital. Things like congestive heart failure, chronic obstructive pulmonary disease, other illnesses that are chronic illnesses for which we have no cure will be checkered by crises events, where they will end up in the hospital. We will do a lot of things, bring them back. They may not be quite to the functional level they were before, but as time goes on, more and more of those insults end up causing such a decline that ultimately we will have a final event where they aren't able to come back from it. 90% of the folks that were surveyed in the Gallup poll not too long ago said that if they were to die, they would like to die at home. That is not generally where the public dies. In the 50s, about half of the deaths occurred at home. With progress in technology, you can see that up until this point, we have about 3/4 of the people die in an institutionalized setting, most of them in the hospital, a fairly large number in nursing homes, and then there are other types of settings that are various facilities outside of the home. Interestingly, the majority of institutional deaths actually could take place at home. We get to a point where we know that we don't have a cure for the illness and that death is indeed the expected outcome. Yet there is a generalized lack of familiarity with the dying process, and a lot of folks are very uncomfortable with having someone in the home when they are dying. They don't feel like they're equipped enough to provide the level of care that is needed. And there are a variety of other resource issues that are out there, including some changes in society that makes it more difficult. The general public has had an opinion that docs are pretty capable of providing care at the end of life and to plan that care in the event of a life-threatening illness. Unfortunately, there is clearly a discomfort in communicating poor prognoses from healthcare providers in general, including physicians, sometimes even physicians that work in populations that have chronic illnesses for which they know they will have no cure. So there is a misunderstanding, if you will, between what physicians are comfortable doing, nurse practitioners, other healthcare providers, and what the public thinks we are good at doing. There is clearly a lack of skill, lack of training, if you will, in terms of talking about treatment priorities and when therapy is futile. And when I talk about futile care, there is an image that many folks have in that we can provide this and this will be the outcome. We can do this and this patient will get back to their baseline level. When in reality, we have lots of information to tell us when certain interventions are not useful. Interestingly, it is somewhat bothersome to physicians as well. Here is a quote from one physician, and it illustrates the problem with a lack of formal training in terms of end-of-life care and how ill-equipped some physicians are when it comes to situations like that. This is a direct quote. They said there was nothing to do for this young man who was end stage. He was restless and short of breath. He couldn't talk and looked terrified. I didn't know what to do, so I patted him on the shoulder, said something inane, and left. At 7 a.m., he died. The memory haunts me. I failed to care for him properly because I was ignorant. By 1998, only 4 medical schools in the country had separate courses on end-of-life care. By 2005, most, if not all, of the U.S. medical schools had such training, but even today, it is not comprehensive. There is a lack of standardization in terms of the curriculum that is offered. And the reality of it is most physicians that are practicing right now have not had an abundance, if any, end-of-life training. There are lots of symptoms that are associated with the end of life when someone has a disease, and those symptoms will have to be addressed when there is not the option of a cure. Some of those are things like pain, and we all focus on pain when we talk about the issue of physician-assisted suicide or euthanasia, things like that. There are other symptoms that can be very distressing as well: nausea, vomiting, constipation, breathlessness, one of the more terrifying things that I've witnessed for patients, weight loss, weakness, fatigue, and any loss of function. As it goes with pain, one of the reasons we have done such a poor job at managing pain is because we don't do a really great job at assessing pain. And formal instruction on how to assess pain often is lacking in medical school curricula as well as in postgraduate training. There is a tremendous fear of using some medications, such as opioids, and there was a time when it was difficult to prescribe opioids without undergoing the scrutiny of various licensing boards. That has changed dramatically, and the Federation of State Medical Boards has put out guidelines for the various licensing boards in the country on how to evaluate and oversee folks who are prescribing opioids. And in general, at this point, there is as much emphasis from most medical boards on making sure that people provide adequate intervention for pain as there is to make sure that there is not a deviation of prescribing in terms of these opioid or Schedule II drugs, as they're called in the profession. There are other issues that patients have in terms of reporting. A lot of people feel, especially older folks, you're getting older, you ought to have some pain with that. It's part of the aging process. It clearly is not. I'm a geriatrician. I have worked in that field most of my career, and I will tell you that pain is not a normal part of the aging process. There is also a stigma of certain individuals about using opioids, sometimes called narcotics, a more disparaging term for those kinds of agents that can be very useful in terms of controlling pain. But even 90-year-olds who have been in the last days of life have expressed to me concern that they might get addicted. And so there is an educational process not only for healthcare professionals but also for patients as well. We have to understand that in this society there is a great risk of social isolation. Americans often live alone. You will oftentimes see even spouses who have had relatively large families. The families are dispersed throughout the country, not local. One spouse dies, leaves another one literally alone. And with relatively difficult functional abilities, being able to get out, even to do shopping, can become a real challenge. We have to also recognize that even when folks live close by, because of a changing dynamic that's happened over the last few decades, we don't have folks that are available, if you will, as easily as in past history. So with the dual income families, we also ended up having few people available in terms of flexibility of schedule. Not to say that people that are home are not very, very busy individuals. I can tell you, my wife with 4 daughters will tell you that as I go out to do this lecture or something else, her job load increases. And anybody who has been at home with a number of kids knows that I'm the one who's got the easy job. And so the reality of it is that level of support has changed tremendously in a society where we see many more dual-income families, and it has put a strain, particularly when it comes to providing care for other family members. Interestingly, however, we still have a pretty common belief that caregiving is a family responsibility. Unfortunately, when it does fall to the family members, it often falls to a relatively few numbers of individuals, and that individual is usually a daughter-in-law, a niece. It's usually not a male. Now, I'll take some exception to that, but I recognize that when you do have those diligent males that are out there providing wonderful care and overseeing a great deal of effort related to that, they have to understand that they are the exception. Also, unfortunately, most folks are ill-equipped to provide that care. They are not trained. They are doing it out of love. Love is great, but it doesn't help in terms of changing catheters or changing wound dressings, and they need some additional training and support. There are also financial pressures. A lot of folks will find, especially in an economic climate like this, that it will be devastating in terms of their financial resources. Coping strategies are such that they will vary from one individual to another. Interestingly, there are some very solid data, scientific data, to tell us that if you are a spiritual individual, your coping ability seems to be better than those who do not have that same background. Regardless, being a caregiver, especially when there's relatively little other support, is a very stressful environment, and it is likely to lead to illness and chronic conditions for the caregiver if they don't get some relief. As we address end of life in this country, we continue to see some changes. We recognize that amongst the older individuals in particular, there are only a few cures that are out there. A lot of folks that I see have chronic disease processes for which I will not have cures. And the older that the population is, the more of these conditions that will accrue. We can do a lot of things to help folks live longer. We can do a lot of things to help relieve some of their symptoms. We can do some things to take that chronic condition that is leading to death and prolong individuals' survival and facilitate their level of comfort and function and their ability to communicate. We can do lots of things. Regardless, however, we still have our limitations. Recognizing those limitations, there are individuals who have looked at other venues, and we heard a little bit about that earlier. Physician-assisted suicide is one of those venues. It's an interesting term, physician-assisted suicide. I often say that. Would physician-assisted bank robbery be okay? Physician-assisted murder, that okay? Why is it that physician-assisted before the word suicide makes it more acceptable than suicide alone? The other thing that you have to ask yourself is, while we think that physician-assisted suicide is going to make it a neater process, make it a more sure thing, the reality of it is medicine is not exact. And there are circumstances where I give a medication or I intervene expecting a result, and I know there's a few physicians here in the audience and they'll all relate to this. They don't respond the way they're supposed to. They all don't read the textbook. And so we have to recognize that I may intervene here There may be an adverse event that's relatively rare, maybe even one that's not been seen before. It doesn't always go as planned, and that is true with physician-assisted suicide as well. Let me give you some statistics. 50% of patients who were in Oregon who received physician-assisted suicidal intervention became unconscious within 5 minutes of getting the lethal agent. The same percentage died within about half an hour. The range of time varied from 5 minutes to 9.5 hours. Now, that's of the ones who actually died. One recipient who ingested the prescribed medication in 2005 became unconscious 25 minutes after ingestion, then regained consciousness 65 hours later. And that person decided, you know what, I think I'm not going to do this again. 2 weeks later, he died of the underlying illness, basically 17 days after ingesting the medication to allow him to have physician-assisted suicide. So we're not as good as a lot of people think, and that's only a few cases that are out there. So you look at 35 cases and you have one like that in the year, and you're thinking, not really a great ratio. If I had that kind of adverse event rate for any medication that I wanted to prescribe, it probably wouldn't get through the FDA. Now, about 12 physician-assisted suicides have occurred per 10,000 deaths, 1 in 800 deaths among Oregonians in 2005, resulting from that physician-assisted suicide. 8 in 10 folks have at least 3 concerns when they think about physician-assisted suicide. And when you look at the list I have up here, a decreasing ability to participate in activities that made life enjoyable, a loss of dignity, a loss of autonomy. Pain is not one of the things on that list, is it? As it turns out, we heard a little bit earlier about people complaining of, well, I don't want to be a burden on anyone. As a clinician, I hear this fairly often, especially when dealing with hospice patients. I will usually have a discussion, and when people talk about that, when they request physician-assisted suicide, which, by the way, is illegal in Maryland, when they request that, I'll have a discussion with them. And I usually ask them, have you ever done anything to help anyone in your life? Of course I have. How'd that make you feel? Oh, I really like helping people. That's one of the reasons I don't want to be here. I love helping people. It makes me feel great. And you would deny somebody else of that feeling? You would keep them from being able to have that same sensation? What kind of person are you? It's a really interesting twist on their thought process when that happens. But it is an interesting dynamic. And one young gentleman who, and this was a very young gentleman, 14, who was dying, one of the things this kid had in terms of insight, when there was a discussion with him about where he was, he said, you know, very strong faith, I am really blessed because I am here to give people an opportunity to do really good things. I will not tell you that I had any insight as to why he was there, but that kid did some great things simply because of his attitude. And he ended up dying shortly thereafter. But there is a program in this country right now where, I won't go into too much detail, but where they give teddy bears to kids that are at the end of life, and it's a special teddy bear. It has a pocket with a heart on it, and there's a whole lot of things related to it. But it is a program designed for kids that are dying. It was in part launched related to that young man I talked to you about earlier. So, physician-assisted suicide issue, getting back to this, the law states that actions taken in accordance with the statute shall not for any purpose constitute suicide, assisted suicide, mercy killing, or homicide under the law. So basically, in Oregon, you can't call physician-assisted suicide because that's unpalatable. They would refer to terminally ill patients who asked for physicians to help them die as persons who use the Oregon Death with Dignity Act. Talk about cowardice. Let's just call it what it is. Physician-assisted suicides were going up until about 2003. Then they sort of plateaued, as you can see from the data there, and the number of prescriptions has also plateaued. While that is somewhat encouraging, if we can find any silver lining to this, it is discouraging that Washington State now has some similar legislation. Let me just quote quickly from John Paul II in his encyclical Evangelii Vitae. By euthanasia, in a true and proper sense, must be understood an action or omission which by its very nature and intention brings about death with the purpose of eliminating all pain. It goes on to say, such an act is always a serious violation of the law of God, since it is deliberate and morally unacceptable killing of a human person. Couch that with the next statement from the American Medical Association. However, allowing physicians to participate in assisted suicide would cause more harm than good. Physician-assisted suicide is fundamentally incompatible with the physician's role as healer, would be difficult or impossible to control, remember what I said earlier, and would cause serious societal risks. Physicians in general are very discouraged from participating in anything like this. Obviously, there are physicians who follow their conscience and do differently, but in general, the profession deems this inappropriate. In part, we have some issues to grapple with, and those are some of the misconceptions that are out there. They generate fears, fantasy, and worry, and many of these things are driven by other people's experiences, third-hand information, or media dramatization. How many of us have seen someone on television in the show die, somebody comes up, pounds on their chest, few quick breaths, and boom, the person is alive, they're doing fine, walking around as if nothing had happened, and thank you for saving my life. I just want to tell you I've done a lot of CPR, it doesn't work that way. A lot of the misinformation is related to a variety of factors. There are things associated with primary illnesses, so we have misconceptions about Alzheimer's, we have misconceptions about cancer. Adverse effects from medications are not fully appreciated by folks. They think that, okay, well, I'm going to take this drug for the Alzheimer's and I'm going to be normal again and I'll be able to drive and visit all the grandkids and I'll know who everybody is. It doesn't work that way. We do not even know the cause of Alzheimer's disease. We don't have a cure for it. And a lot of our medications that we think are going to be very useful, whether it be chemotherapy for cancer or other interventions, are not helpful. Experimental therapy is just that. It's experimental therapy. We don't know what the outcomes will be. We have a lot of folks with cancers that are encouraged to take things, and when you say, is this going to work? I actually witnessed an oncologist with a patient of mine say, well, I've seen people respond. And then we went further and said, what percentage? Well, I don't know for sure. More than 1%? Well, probably not more than 1%. More than 0.5%? More than 1 in 1,000? When you start talking these kinds of numbers, you get a better sense of what we like to describe as information for informed consent, which is unless you really understand what are the pluses and minuses, it is hard to make a decision. But if you're not presented all the information, it is difficult to know what path to take. There are intercurrent illnesses with a lot of folks, and many things that we'll do are based on one diagnosis. I am trying to think of any patient in their 80s that I have that has only one diagnosis. And this interaction of diseases along with medications makes prescribing a daunting task. We also have misconceptions and inadequate information about interventions. I have seen a gastroenterologist come into a family with a patient of mine who is end stage, having some aspiration, and say to the family, you don't want to starve your mother to death, do you? Of course you want a feeding tube. That's not the option. We have to recognize that some of these interventions are likely to cause more harm than good. And there is no precedent for any of us, for religious reasons, for medical reasons, for any other reasoning process, to do something that is going to cause more harm than benefit. As it turns out, artificial feeding, there are no studies to show benefit of a tube feeding in an individual who's conscious. In fact, there are data looking at individuals where we have video esophagograms, that is something called cine-esophagograms, that show us people swallowing food and part of it going into the lungs, part of it going down the esophagus, the tube that goes into the stomach. We know the population that we're evaluating has mild to moderate aspiration. A study was done saying, okay, let's put feeding tubes in half of them and no feeding tubes in the other half. The people with the feeding tubes did no better. In fact, there was a tendency for them to do worse than the people who had no feeding tubes. So the idea that I'm going to put a feeding tube in it's going to absolutely be a good thing is not always true. And so we don't want to do things that are not going to be useful in terms of prolonging life. Regardless of the issue of quality life, if I'm going to do something that's going to make it worse, I certainly don't want to be doing that. IV hydration is a very complex matter. You watch TV, they put in the IV, the person wakes right up. Thank goodness House was there. The reality of it is just putting in normal saline, basically a little water with some sodium, is a complex process, especially for an older adult, especially with a variety of disease processes. And we know that in many circumstances, IV hydration is fraught with more complications than benefit compared to oral hydration. We really try to avoid that, especially in frail older individuals. CPR. Less than 5% of MI patients survive CPR, so heart attack patients. And interestingly, almost all of them are in a monitored setting in the hospital. It is far less than even 1 in 1,000 that would survive if they were to get CPR in a nursing home or out in the community. Very different than the image that gets cast on television. We are very likely, however, in a lot of my frail older patients, to cause them a great deal of discomfort if they have any level of consciousness. We will crack their ribs. We will inject them with a lot of things. We will shock them. If any of you have gotten a little static electricity, it ain't nothing compared to what happens when we shock you with the defibrillator. So if it's not going to be beneficial, it is something that we don't want to do. We do have other options that are out there that also are not fully understood. Hospice, for example, started in the 70s. We have had a greater percentage of individuals that are recognizing hospice as a benefit. Up to a third of individuals now with chronic diseases are getting there, but we still do it too late. For people with Medicare, you have a hospice benefit to which you're entitled benefits, which provide comprehensive care to individuals. And you are entitled to those benefits when you have less than 6 months to live. Average length of stay, about 3 weeks. Median length. Palliative care programs, they are out there, they're abundant. We need to take advantage of those as well. There is a spiritual component that's also provided with those. Diagnoses for hospice, we've started to recognize that non-cancers kill more people than cancers, and we're seeing better enrollment with hospice for non-malignant diseases. People have worried that if we increase morphine, we're going to have a problem, and that if we instituted the law of physician-assisted suicide, that would be a problem. Not at all. As it's turned out, it hasn't had a chilling effect, as opponents talked about when we were talking about this legislation in terms of pain management. In fact, it has had just the opposite. More morphine is prescribed in part because the legislation is written to give physicians protection when they prescribe opioids, even if there's a chance that it would hasten death or that it would increase the risk for death. Docs are protected, so now they know that they can intervene with adequate pain management without fear of legal reprisal. And in fact, the state of Maryland has risen since we've had the physician-assisted suicide ban in terms of per capita use of morphine in the country. I will close with this, showing you a slide of this patient here who is dying. Doesn't look like she's dying, I know. She was able to link up with her son, knowing that her pancreatic cancer was going to progress. She decided not to get additional chemotherapy or any type of surgical intervention. She made this trip around the world with her son. They had been estranged, and at the end of the trip, the two were the closest that they've ever been in their lives. Here we are with Mount Vesuvius in the background. Let me close with a final poem. I must go down to the seas again, to the lonely sea and sky, and all I ask is a tall ship and a star to steer her by. I've always thought about giving a poem like this and then forgetting a line. I only had a pause there, but it was an impressive pause for me. The wheels kick, the wind song, the white sail shaking, the gray mist on the sea's face and the gray dawn breaking. I must go down to the seas again, for the call of the running tide is a wild call, a clear call, it may not be denied. And all I ask is a windy day with the white sails flying, and the flung spray and the blown spume, the seagulls crying. I must go down to the seas again, to the vagrant gypsy life, the whale's way, the gull's way, where the wind's like a whetted knife. And all I ask is a quiet sleep, is a merry yarn from a laughing fellow rover, and a quiet sleep and a sweet dream when the long trick's over. Somewhere between Dylan Thomas and John Masefield, we have a path to follow. It is a spiritual path to provide comfort and dignity and to recognize our own mortality and to make sure that we preserve the sanctity of life but assist people in getting into that next greater life. Remember, he had another poem, Death Shall Have No Dominion. Thank you.